Welcome to PEM Pearls. I'm Ashley Foster and I'm with Delphine Wong and Sunny Tat from the UCSF Pediatric Emergency Department. Today, we will be talking about how to approach a laceration repair in a toddler and how to prepare your pediatric patient and patient family for any other potentially scary procedure. We worked with Lauren Meyer, one of UCSF's child life specialists in the emergency department, to develop many of these tips. So imagine, it's your typical busy day in the emergency department, and just as you thought things couldn't get more hectic, in walks a toddler with a laceration to the forehead. You have flashbacks of your last pediatric laceration repair. There was screaming, both by you and the child, for very different reasons. As if you weren't worried enough, children who have bad experiences with invasive procedures can lead to difficulty coping with future procedures or fear of the medical system later in life. Fortunately, there are some tips and tricks that you can use for your next pediatric procedure. It's all about the setup. This is the time to use people around you to help, including nursing, child life if available, and parents or guardians. We encourage families to stay and help with the procedure, but it is also okay if they would prefer to leave while the procedure takes place. If they choose to stay, one of the ways that parents can help get involved is to use a comfort hold. This usually means a parental hugging hold or simply close physical contact during the procedure. Using this technique can decrease the number of staff needed to complete the procedure, give parents an active role in comforting the child, and give the patient a sense of control over his or her actions. Perhaps the most effective non-pharmacologic intervention we have for invasive procedures in children is the art of distraction. Distraction refocuses by moving attention away from the pain associated with an invasive procedure. Distraction techniques shown to be effective include blowing bubbles, movies, cartoons, music, toys, video games, counting, and even hypnosis. The nice thing about this list is that many of these distraction techniques can be used by anyone, anywhere. With many types of distracting techniques that can be used, if possible, it is best to give the child a choice in the selection. Give the child the power to choose the distraction activity, and this may help with the feeling of loss of control involved in treatment. This may be as simple as allowing a child to pick bubbles over a story or pick the type of sticker after the procedure. The use of soft language can be valuable when explaining a procedure to a child and family. Take a laceration repair as an example. When explaining the process of local anesthesia to a child, instead of saying a needle stick, you can say a pinch or a poke. Additionally, to explain a lidocaine injection, you can try avoiding the word burn and instead describing it as a warm feeling. Generalizing can be helpful. For procedures that allow for different types of positioning, such as laceration repair or abscess drainage, try to keep the wound area out of the child's line of sight. This can be done by placing a visual block with a blanket or book. If the laceration is on the extremity, providers can use their own bodies as a block. It is helpful to use this technique in conjunction with active distraction. For example, use a book to visually block the wound while reading to the child. Now let's talk about the wound itself and ways to make repairing the laceration more comfortable for the child. There are ways to reduce pain while numbing, irrigating, and closing. First, if you have this available in your department, try using topical lidocaine. The agent most commonly used is LET, lidocaine, epinephrine, and tetracaine. Instead of placing the LET on the skin and covering it with gauze, place it on a cotton ball first and then apply the cotton ball to the wound for at least 20 minutes. The cotton ball is less absorbent than gauze, so it seems to allow more LET to get into the wound. In relatively shallow lacerations, LET alone may be enough to suture a wound. At the very least, LET can help with the pain associated with the lidocaine injection. If you do need to inject local anesthetic, you can reduce the pain and burning associated with lidocaine by buffering it. Mix 9 parts lidocaine, 1 part sodium bicarbonate immediately prior to the procedure. Warming the lidocaine and bicarbonate mixture to room temperature can also help with the pain on injection. Irrigating after local anesthesia means you're squirting water into a numb wound rather than a sensitized one. Using warm water to irrigate can also make irrigation less unpleasant and jarring for the child. We keep our irrigation bottles in the blanket warmer to keep them warm and ready to use. You can also try pulling on the ends of the wound to approximate the edges instead of squeezing them together. It approximates the wound a little more naturally and gets your fingers out of the work field. This can be especially useful when using skin glue. Pulling on the ends of the wounds makes it less likely that you'll glue your own finger to the wound. A cool trick for scalp lacerations is to use the hair as a suture, called hair apposition technique. Use your hands or Kelly clamps to take strands of hair on either side of the laceration. Twist them together and place 1 drop of glue on top of the twist. This is a relatively pain-free way of closing the wound. Please refer to the ALIEM blog post from 2010 for more information. When a child presents with a wound, even if vaccinations are up to date, he or she may still need a tetanus booster. This quirk is because of how the childhood vaccine schedule and tetanus prophylaxis are set up. Just like in adults, children who have not had a tetanus shot in the last 5 years should get a booster for a wound that does not fit the description of clean and minor. Most children have a series of 5 tetanus vaccinations in their first 5 years. However, they may not get another booster until around 12 years old. This means that an 11-year-old may be up to date on his or her vaccines but still need a tetanus booster for a wound because it has been more than 5 years since his or her last tetanus shot. The same goes for a 17-year-old who last got a tetanus at 11. So instead of asking if shots are up to date, it's better to ask the specific question of whether they've had a tetanus booster in the last 5 years. Finally, children under 7 years old should receive a DTaP, while everyone else gets a Tdap. In summary, pediatric laceration repairs don't have to be scary for the patient or the provider, and using simple techniques can make a huge difference in minimizing fear and discomfort. Take the extra few minutes required to set up properly, and this can save you time and stress. When possible, position the patient with the parent, use distractions, and give the patient as many choices as possible. When describing the procedure, use soft language and allow the child to see the equipment that will be used. Once the procedure is started, try to block the patient's ability to see the wound. For wound management, when feasible, use topical anesthetic first. For scalp lacerations, consider the hair apposition technique. Thank you so much for listening, and a special thank you to our child life specialist, Lauren Meyer.